I'm Morgan Fader. I think you've all met me now. So I always am condemned to speak right after lunch, so I'm going to try to keep this entertaining. But, if you fall asleep, I'll forgive you this time. All right. So, okay, all right, I have no disclosures, unfortunately. So, yeah, this is a nice picture of a brain, which is why I show it, because I like the pretty colors. HD, as you all know, is complicated. It's really complicated. It affects movement, affects thinking, affects behavior. And basically that means it affects every aspect of somebody's life. And that's what we're all sort of trying to deal with in practice when we're dealing with people and families who are affected by HD. So there are a lot of behavioral issues in Huntington's. They can be the first symptoms. They're related to changes in the brain directly, and they interact with the stress that's related to HD. So having HD is stressful. Also, stress unrelated to HD, and all of these things sort of come together to make things, hard for people and hard for families who are affected by HD. And we're trying to give them some help with these things, both by using medications and environmental and behavioral treatment as well. So, describe some of the common behavioral issues. Some of this is going to overlap with what Dr. Valpi was talking about earlier, just sort of the nature of the business, I think. And we're going to also talk about how to deal with some of these things in a variety of different settings, at home, in facilities, by people who are related to, unrelated to, have some interest in caring for the person, or just basically are paid to care for the person who has HD. So common symptoms are depressed mood, suicidal thoughts, anxiety, kind of very black and white, either or type thinking, perseveration, just going over and over on things, which actually leads me to want to comment a little bit about the case that Dr. Valpi presented. It struck me, and I hadn't actually thought of this before listening to her presented in this context, that we were dealing with the patient one who has HD and who was dealing with trying to get disability, and really her HD and very legitimate issues with needing financial support, needing to be, continue to bring in something for herself and her family. Those things interacting, she was perseverating on getting disability and always bringing the conversation back to that. But a more dynamic issue within the family was then that's a really easy thing for people to latch onto as caregivers, to say, oh, here is a problem that we could potentially solve. Let's put our emotional resources into trying to solve this problem. And maybe some of these things that are a little bit harder to deal with, we're going to put those on the back burner, because here's something that we can work on. So the patient and the family, the disease, and sort of the dynamic issues within the family sort of all come together to put the emphasis on the one problem that people think they really can address here, and may lead to neglect of other problems, even if they need to be sort of brought to the forefront. So I just wanted to sort of put that in there. And then disinhibition, and sort of the opposite of disinhibition, apathy, aggression, poor insight, all of these things are really common when people with Huntington's. And then there are the underlying problems that may be contributing to or causing these symptoms, depressive disorders, anxiety disorders, the very real degeneration of the frontal networks that is part of the disease process of HD. It's thought of sort of technically as what we call a subcortical dementia as it progresses, where it's affecting connections within the brain, basically connections of the frontal lobes to other parts of the brain. And as those things degenerate, you get real problems with things like disinhibition, apathy, aggression. And then substance use disorders are really common also within HD, both because of people, for lack of a better term, self-medicating in order to deal with the stresses of having it, and also then coming into the disinhibition and the sort of poor decision-making that can come from parts of those, part of the degenerating cortical processes. So one thing I want to stress here is that suicidality is a huge issue. It's up to 20 times more common in Huntington's patients than in the general population. You'll see lots of different numbers, and I picked the the big splashy one here to sort of drive home the point that this is really common and really needs to be addressed. But, it ranges from being thought of to about 4 to about 20 times more common. And then it encompasses sort of also a wide range of ways that this presents, from thoughts of being better off dead, family being better off without me, those sorts of things, almost more of a hopelessness. Things aren't going to get better for me, so it would be better if my life were just over now. We call that more passive death wish than actual suicidality. But then ranges to an overt wish to die, and at its extreme, not only the wish to die, but a plan and intent to end life. And this is sort of complicated, unfortunately, by attention-seeking behavior that sometimes we'll see in any number of different kinds of illnesses, HD being among them. And when people are dissatisfied with their lives as they are, they have maybe maladaptive coping mechanisms, which tend to be more common in people with HD because of the devastation that Huntington's wreaks on family structures. So if you think of somebody who grows up in a family that's affected by HD, sees a parent affected by HD, maybe the parent isn't able to be as effective at parenting, not as effective a role model in terms of living one's life because of the illness. Then the affected child with HD has less in terms of emotional resources, cognitive resources to draw on, leads to a cycle of maladaptive coping within the family and within the illness. Usually, when people are seeking attention, the sort of cry for help with suicidal behavior, the intent is really to get help, but the result, unfortunately, can be fatal, even if the person who is making a dramatic gesture in order to call attention to their need for more care did not mean actually that they wanted to die. What they wanted was, hey, please, I am suffering here. I need help with my suffering. So we get into the sort of complicated, why is this all happening? Anyway, individuals who are expressing suicidal ideation, no matter whether you think that this is a call for help or actual intent to die, really need to be evaluated by a mental health professional and quickly. So that said, families and caregivers are essential in maintaining safety, both after and before evaluation by a professional. They can be a very large part and should be a large part of formulating a safety plan for the patient. And we as professionals can help them do that. And it's quite possible that their first point of contact will be with an HD social worker rather than with a psychiatrist or some kind of mental health therapist. And so you can actually help them to formulate a safety plan even before they get in to see a psychiatrist, because unfortunately, we're not that easy to get in to see fairly often. I heard that. And so the things that we think about in terms of formulating a safety plan are things like either getting rid of guns from the environment or securing them really well, locking them in a safe, keeping the ammunition separate. I live in Western Pennsylvania. There is a huge gun culture in Western Pennsylvania. I don't know if where you all are from that's the same. I cannot talk to people without saying you can't own weapons anymore, because that, my alliance is shattered, basically. When somebody grows up hunting, that's part of the culture. But what I can say is, let's talk about gun safety. Let's talk about who has access to the weapons. Let's talk about under what circumstances they have access to the weapons. Let's talk about, making sure that the ammunition and the gun are not in the same place so that anybody who might have some impulsive decision-making cannot get both of them at the same time. Just putting a barrier in between the mode of suicide and, and the person's intent to act, just even a barrier in terms of time or effort, decreases the chance that somebody will actually act on their suicidal thoughts. So any barriers we can put in the way of access to lethal means, it is a good deed done. We also want to limit access to medications. Somebody may be cognitively perfectly capable of managing their own medications, and yet if they're having suicidal thoughts and they have the impulsivity that goes with Huntington's or with some psychiatric disorders completely unrelated, they may see that bottle of their pills and say, oh, maybe it would be a good idea for me to just take these all now and down the bottle, and then you've got a serious problem on your hands. Usually those kind of overdose attempts are not fatal, but they are still very serious and often require very serious medical attention. So giving families, ways to limit access to medications. Maybe a family member will give the affected person only a week's worth. Maybe they'll give it on a day-to-day basis, involving families in that. When people are quite serious about having a plan or an intent to harm themselves, it may require 24-hour supervision on the part of families to keep that person safe until they can come in for an evaluation. That said, if families are not feeling that that is safe, bringing them to the emergency room, calling 911, bringing them, some facilities have dedicated psychiatric emergency rooms. Not everybody does, but bringing them to the right place where they could possibly be admitted for inpatient psychiatric care if suicidality is a serious, imminent concern. Safety plans are best if the person who the plan is being made about is in on the planning, as with most things. So what we ask people is, how are you going to let us know that you're suffering? Some people are going to be fine with saying, hey, I'm really feeling bad right now. I am feeling like my life isn't worth living. Please help me, if you say, that you're open to hearing that. Some people are not going to be able to be so open about it. They may have different ways that they're going to cue the people around them into the fact that they need more help than they're currently getting. And that's very individual. But talking to people about how do you want to tell us that you're suffering is usually a good way to institute those conversations. Other things, how can we help you feel safe? What can we do for you to make you feel like you're not at risk of harming yourself? Because often, people who have suicidal thoughts, they're terrified by them, especially if they don't really necessarily want to die in the moment that they're telling you about it, but they're afraid that they might act on that because, maybe yesterday, or they're afraid in a couple of days that they're actually really going to be tempted to act on those thoughts. And then you want to talk with families and talk with patients about when hospitalization is necessary to preserve safety. So, and so we think about that when suicidal thoughts are overwhelming, and when the affected individual just basically can't function as they're used to functioning, maybe not feeding themselves, not caring for other basic needs, things like showering, doing basic things around the house to care for themselves, or if they have a plan or have made an attempt to harm themselves. Even if there isn't a plan or has not been an attempt, if there's a history of impulsive self-harm, that's also a red flag where we would bring that person into the hospital sooner rather than later. Different states have different indications for involuntary commitment. In Pennsylvania, you have to have basically an intent to harm yourself or somebody else, as well as an act of furtherance, some action made in the furtherance of that attempt. Basically, if you say, I feel like I want to kill myself, and I went and I bought a gun, that qualifies for that. If they say, I'm really thinking about hurting myself, I'm thinking about buying a gun, but I haven't done it yet, or I'm thinking about doing this, in Pennsylvania, that's not enough for somebody to file an involuntary commitment, but it really varies by state. So familiarize yourself with the regulations where you are. And also familiarize yourself with crisis resources in your area. We have county crisis teams all over Pennsylvania where you can call and they'll go out and check on somebody or involve the authorities if necessary. I think in Allegheny County, we have better resources than most places, but even in our surrounding more rural counties, they have county crisis teams that can help people out. Again, that varies by location, so you kind of need to know where you are. And then there are national resources where there are suicide hotlines. So some targeted at different populations, but there are national suicide hotlines. And I think I meant to put those in there and actually didn't get to doing it, so I apologize for that. So other things to watch out for, and this isn't directly related to suicidality, but in terms of, I think one of the things that I was asked to comment on are what are red flags for families and caregivers and patients for that matter, where they're going to need more help, where families should be more concerned about getting them in for an evaluation sooner rather than later. Things that we worry about particularly are social withdrawal, particularly sudden social withdrawal. We worry about depression, worry about anxiety, cognitive impairment, a quicker cognitive decline than you may have been seeing before. Irritability. If somebody starts getting more irritable sort of all of a sudden, then we worry about depression, cognitive issues, but also things like a new physical illness, something that somebody can't tell you about because they may not have all that much awareness of it, or they may actually not be able to communicate so well. Everybody sort of starts getting more irritable when they're not feeling well. I know I certainly do, but people can have pain that leads to irritability, or it can be a medication side effect that needs to be looked into sooner rather than later. If there's any new aggression, then that's something that we as providers want to hear about sooner rather than later. This can be linked to depression, cognitive decline. These are kind of repeating themselves here. Physical illness, pain, again, more impulsivity. Again, we're concerned about cognitive decline. People who are asking for more attention than they had been before, just kind of being, a little bit more needy, for lack of a better term. Again, we worry about the same sorts of things. And anybody who starts telling us that they're having perceptual disturbances, hallucinations, delusions, then mostly what we're worried about is not a new psychiatric problem or a new behavioral problem, but a new medical problem. We're thinking about delirium, like Dr. Delphi had talked about in her talk. And it's usually symptoms like that are scary enough to caregivers and to patients that they will voluntarily say, hey, wait a minute, something's wrong here. I need help with it. But it's good to ask about these things as well, and good to, in some sense, even though these symptoms are not normal, normalize them in the sense that when people start experiencing these things, it doesn't mean that they're suddenly, quote unquote, going crazy. It means probably that there's something physical going on that we need to be looking into, and that we can help with those things. Okay, so the big question, drugs or therapy when it comes to treating a lot of behavioral issues. I know I was told to keep this professional, but I wrote this talk beforehand, so the dog is on the couch telling the psychiatrist, I have a fear of castration, my mother's a bitch, and I feel guilty for lying on this couch. So what are we going to do with that? Okay, so, and then the other thing that I always emphasize to everybody is that stress makes everything worse. There's no problem that stress ever helped, except maybe me writing a talk. But so a lot of our interventions are geared towards bringing down the everyday stress level for people, especially a lot of the behavioral interventions, because everything is easier to manage if there's not that extra load on the system of just more stress. We can do it sort of based on symptoms, anxiety, or based on why it is that we think people are having those symptoms. Okay, things like unmet needs. We can make hypotheses about why somebody is behaving the way that they are, even if they can't tell us, oh, I'm, like if I were to say, I'm worried about writing this talk, and I'm getting really snippy with you. And my husband says, yeah, I know. Okay. But when somebody can express their thoughts or feelings, we can usually base our treatment on what they tell us. But it's more complicated when people's cognitive impairment tends to get worse, because there's more of this issue of a lack of awareness of what's causing a symptom and what the symptom is. Sometimes people can't tell you the symptom even. They can come to you and say, oh, I don't really feel like doing things any longer. I'm not sleeping well. I can't concentrate. I kind of feel like I would be better off dead, but no, I'm not depressed. I don't feel depressed at all. I think everything's fine. So that's sort of lack of awareness. All right. So we have a bunch of interventions that basically I like to teach to both patients and caregivers. So these are the sort of home do-it-yourself interventions that work really well just to sort of bring the stress level down, help people to cope with whatever it is that they're dealing with, and sometimes actually sort of treat the anxiety and the depression that they might be feeling. The first level of these is sort of things like grounding, deep breathing, relaxation techniques. These are all really pretty easy to teach to people in a short session that can make a huge difference in terms of how they cope with the world around them. So things that I like to tell people about grounding, most of this stuff is based in dialectical behavioral therapy, but most of dialectical behavioral therapy is based in other things. So these things are all over the place. But where I came to it is from DBT. So, grounding. Somebody gets acutely anxious. They may feel like they're going to be panicky. What can they do in the moment if they can remind themselves to do some of these skills? Grounding is one of those ones that people find really, really helpful. So one of the things you can tell them to do is, okay, look around yourself and name all of the things that you see. So I'm getting really anxious about giving a talk and I don't know what's going on. And now I don't know if I'm going to have a computer, and my brain starts to catastrophize and who knows what's going to happen. I say, okay, Morgan, just bring it down a notch. Oh, over there's, a bag and a few chairs, and my colleague, Dr. Valpi, is sitting there giving me encouragement. And all right, I'm back kind of in my body now. I can go on with this. You can find things that meet different, that fit into different categories. You're like, okay, all right, I'm still really anxious. Now what I'm going to do? Okay, there are some red things in this room. There's a chair and I don't know. Well, there are a lot of chairs. Okay, there's something red over there. There's probably a can of Coke over there too. All right, great. Now I've basically taken my cognitive processes and just interrupted that cycle of anxiety, where everybody knows this feeling. Anxiety is like the one psychiatric symptom that is totally normal. Everybody feels it at some point, and we treat it when it gets problematic. But what we want to do is sort of bring our cognitive processes in to interrupt that cycle of working oneself up. And you can teach these things to people pretty easily. Another technique that I like is to really focus in on one object and think of all of the things about it, all the ways that you can to describe it. And I'd say this to people, is describe it like you would to a Martian. So somebody from Mars comes to Earth and they have no idea what a bottle of water is or what it would look like. You say, hey, get me a bottle of water from over there. My throat's a little dry from talking. And the Martian looks at you and says, what's a bottle of water? You say, well, it's clear and it's colorless and it's got a black cap on it. What's a cap? Oh, it's this thing that goes on top. And again, you're just bringing your cognitive processes in to interrupt the cycle of anxiety. And these things, different people will find some of these things more helpful than others. Deep breathing is always good. Usually it's the first thing people do. A lot of people do this just completely reflexively, whether they've been taught to do it before or possibly they just do it because it, again, calms down sort of the autonomic nervous system. For a variety of different reasons that I won't go into. But you can breathe in to count of 5 and out to 10. Repeat it. Ooh. Another thing is progressive muscle relaxation. People often find that really helpful when they're trying to go to sleep, where they start at one end of their body, usually the feet, and relax all of the muscles, say in the foot, the ankle, the leg, move it all up to the head. And, sometime around the belly button, they're already asleep. But that can be helpful, not usually in the moment, but it can be helpful when people feel like they're going to be in a stressful situation or when they've managed to remove themselves, say, from a stressful situation and sort of want to calm themselves back down and get back to themselves. Okay, another one, I think that Dr. Valpi talked about distraction in terms of dealing with anxiety and agitation. One can distract oneself. That's what cell phones are for. Among all of the wonderful applications that Dr. Valpi showed us, the number one use I make of my cell phone is, oh, this is really not a good situation. I think I'm going to look up X, Y, or Z. So really annoying to people who are trying to talk to me at times. But also family, friends, caregivers can say, hey, remember that you really liked doing that adult coloring book. Why don't we do that now? They can offer an anxiety. They can offer an activity that they know that the person that they're working with finds enjoyable. Why don't we go for a walk? Why don't you tell me about that activity you did with so-and-so the other day? Draw them out, talk to them, give them some distraction from the thing that's making them acutely upset in the moment. Sometimes if somebody is really perseverating on something, this takes a lot of work, but you can often even drag them out of something that they're very stuck on. And then when somebody's not anxious, you can work with them for to to one, to learn these techniques, but also to do things like make an anxiety box or a comfort box or whatever you want to call it, whatever they want to call it. They can make a list of things that help them calm down. It might be taking a bath, drinking some tea, playing Call of Duty, whatever it happens to be. I know that does calm people down though. And they, write each one of those things on a scrap of paper, put it in the box, and then when they get anxious, instead of having to think of these skills that you've gone over with them, they can just draw one out of the box and try it and see, okay, if that doesn't help, draw another one out of the box and try it. This can also be done with things like positive thoughts and affirmations for people who are feeling maybe more depressed than anxious or feeling demoralized. They can remind themselves of good things in their lives. And that can be really helpful for people. I was talking to a patient just the other day who had done this and said, wow, this helps more than all that medication that you gave me. Okay, good. I'm glad that worked. So another thing that we can do with people, and this is for people who are really cognitively doing pretty well, is thought restructuring. So this is from, instead of DBT, this is from CBT, cognitive behavioral therapy. You can lead people through restructuring what we call sort of negative cognitions or maladaptive cognitions. So if I'm thinking, oh, I'm feeling really down, that pair of pants I bought the other day doesn't fit anymore. Yeah, I'm just a lazy slob. I can take that. That's not real helpful, right? I mean, that's not going to get that pair of pants to fit any better than it did, when I just tried it on. What am I feeling? I'm feeling, kind of down. I'm thinking all these really negative things about, my appearance. But what are the facts? Well, the facts are, that pair of pants fit last week. Probably they'll fit again. Is this really a reflection on my character? Probably not. What's a more realistic thought? Maybe I need to cut back on the amount of dessert I'm eating, or I have to have only one beer instead of 3, for any number of reasons. Maybe that's what I need to be thinking rather than, oh, I'm going to try to say this in a professional way. You're really not doing what you're supposed to be doing. And then have people reflect on when they're thinking more realistic thoughts about their or more realistic thoughts related to these things that they're feeling. How do they feel after that? And usually you can say, oh yeah, okay, I can see this in a more balanced, realistic way. Then mood actually improves with that. And so you can lead people through these things. You can teach families to lead people through these kind of thoughts as well. This is when people are in a good place. You can't teach these kind of skills when they're actually in crisis. I think that's pretty self-explanatory. But and then the other things that people can do is particularly for depression is some activation where families and caregivers can encourage them to do things that they've enjoyed doing in the past. Even if they don't really enjoy doing it now, there's some benefit over time to continuing to engage in things that people have liked in the past in terms of improving mood and treating depression, even if they're not actually enjoying them in the present. So saying, you used to really like to swim. Let's go do that. Like, I don't really feel like it. I don't want to. No, I didn't like it that much. But then over the next couple of weeks, if they're engaging consistently in things that they've enjoyed in the past, they tend to start feeling better. Exercise is one of those things that sort of recruits other systems in the body to help support the brain. There's a lot of good evidence that exercise, even fairly, modest exercise, is really helpful for mood. Sometimes people with HD, the movements will get in the way of being able to do a lot of things, but they actually don't get in the way as much as one might think if you structure the activities reasonably. People can still do stretching. Even if they can't walk, they can do some stretching. It may need to be guided. It may need to be assisted, even physically. But people can move their bodies in a way that feels like they're accomplishing something and feels pleasurable to them. And it's worth doing it even well into advanced illness. What else can we do? Okay, for apathy. I think Dr. Valpy brought this up too. When people are apathetic and they don't feel like doing anything, set a schedule. Sometimes it's setting a schedule by the hour, by the half hour. 8 a.m., I'm going to have breakfast. At 7:30 a.m., I'm going to get up and take a shower. At 9, I'm going to go for a walk. And all of these things, and people sometimes, well, usually need help keeping to the schedule, because if they're apathetic about doing the things to begin with, they're also going to have apathy related to keeping to the schedule. This is where families and caregivers come in, saying, hey, remember you were going to do this. And often people who have apathy aren't really going to fight back against it, because if you're doing the thinking and the activation for them, they're just kind of going to go along with it, which isn't always the case, because some people will really fight back. But oftentimes, when the apathy particularly is due to problems with frontal lobes or connection to the frontal lobes, just doing the cognitive work of the activation for them will help them move on and get things done, and continue to engage in things. And families, sort of along this line, can plan activities. Okay, we're going to get up and we're going to go to the grocery store and we're going to go shopping, and you're going to pick something that you like to eat. And, they may continue to sit on the couch and not get up and put their shoes on. And you're going to say, okay, we're going to do this now. Here are your shoes. Whatever it is, but don't take no for an answer. Just keep going with it. And, they'll get up and do stuff. And it's good for everybody. And it's good for families, too, to feel like they're having some effect, doing something good for the person that they care about and want to see do well. What people can do at home when people are aggressive, the most important thing is to recognize and avoid triggers for aggression. These are usually things like fatigue, hunger, overstimulation, and on the opposite side, boredom, pain, or frustration. This is going to be really individualized, and it may take digging pretty deep down into examples of periods when people have become aggressive or agitated to find out what the thing underpinning the aggression is. But it's definitely worth doing that, because when you can avoid things that are really difficult for people to deal with, it can take the stress in the home down by a huge amount. So often one of the things is going to be hunger. People notice that the affected person at 11:30 in the morning suddenly just can't deal with anything anymore. And okay, it's almost time for lunch. We need to build in more snacks. And sometimes that's enough to just get everything sort of back on track, because feeling hungry is pretty unpleasant. And when you don't have the sort of top-down behavioral control that you did before Huntington's was more advanced, then you may not be able to control that the way many of us would be able to. Similarly, things like pain. When I present the case that I'm going to go through, that's going to be a big part of it, actually. Overstimulation can be huge, too. Many people with Huntington's live in a household where there are a lot of other people. There may be small children. They may be their small children. They may not want to say, hey, I can't deal with these kids running around and all of the noise from their toys, and because our kids' toys all beep and make all sorts of noises, right? You may have to come up with plans for, when mommy or daddy is feeling overwhelmed, we're going to have a plan for what we're going to do with the kids. Or that's quiet playtime, and we're going to put away all of the beeping toys and that sort of thing. And the other thing, so that's sort of adjusting the environment to make things easier, but distraction also can be helpful. Although some things you can distract from. Hunger, you just feed somebody. Frustration, distraction is pretty good. People, when they've got advanced movements or they've got a lot of rigidity, if they've got sort of the akinetic rigid version, maybe can't do things like tie their shoelaces any longer. And that can be really frustrating, because, a grown adult not being able to tie their shoes or not being able to walk across the room to do something for themselves is really frustrating. Combine that with sort of the frontal cognitive problems, and that's sort of a recipe for, I am going to pick up the nearest thing to me and throw it across the room because I am so frustrated. And so then sometimes we'll enlist occupational therapy to say, okay, how do we make this task that is so frustrating to this person easier? What kind of adaptive equipment can we bring in here? What other strategies do we have? Maybe buttoning buttons. The little ones are pretty hard, especially, the ones on your sleeves, right? So, there are a lot of things that we can do, and this is great where the multidisciplinary nature of treatment really comes in. It's like, all right, physical therapy, what do we need? Occupational therapy, what do we need? And it's just amazingly helpful. Okay, so what do caregivers do in terms of behavioral interventions when we're not so much doing symptom-based treatment, but trying to find out what the underlying issue is, or make a hypothesis about needs that the patient may have that are unmet? This kind of approach can be useful at home, particularly when people are kept at home into advanced illness. But usually this is the approach that's taken at care facilities, at least if the care facility is doing it right. We can hypothesize, is the person bored? Are they having actually sensory deprivation, some need for relaxation, or are they overstimulated? Are they lonely? Are they in pain or in some other kind of discomfort? And there are, you probably can't see that all that well. I hope it printed out okay. There are these sort of decision trees that can go along with this, that facilities can use to say, okay, we're just going to kind of go down this checklist and say, okay, let's see, are we looking at boredom, anxiety, deprivation, need for relaxation? Let's see, we can offer a structured activity. Let's see what happens there. Is it, does this person do better as an individual, one-on-one with somebody? Do they do better in a group setting? Do we have some kind of group activity? Yeah. Yeah. Sure. Mm-hmm. The question was, or statement of truth was often difficulty in communicating is one of the things that causes a lot of frustration, in terms of caregivers not understanding what somebody is asking for, and that causing frustration and then leading to behavioral problems. And yeah, sometimes people will need adaptive communication aids. Sometimes we can bring in things like, I can't remember what they call boards, where people can point at the things that they need, communication boards, or they can, if they're cognitively doing okay, but their production of speech is not as good because of the Huntington's, you can have them spell out words or point to common words and spell out less common words on these communication boards. That can be really helpful. And, so just saying, being able to say, I'm hungry, or, that kind of thing. Sometimes offering a list of choices to people who aren't communicating very well, where they can indicate which one is the closest thing to what they're looking for, can be helpful. And then, so there are basically a bunch of these kind of decision trees that facilities can use to figure out sort of how to help somebody who's having trouble. As you get to know an individual, and as the facility gets to know an individual, then they're going to know sort of what things to go for in general, but this is a good place to start. Here's another one for when loneliness is the unmet need. So somebody needs social contact. Again, do they appreciate human contact? Or actually, there are these sort of robotic pets that they're using in some care facilities. There was one study that I read where they use a robotic seal that the residents of the care facility can take care of and provide affection and simulated food. I guess I don't think they have robotic fish to give the robotic seal, but where they're caring for this kind of pet, and it's actually just very sweet. And so there are a lot of different ways to address these issues. Sometimes interaction with another real live person can be too complicated for somebody who's really struggling to deal with, and they actually do better with a simulated contact, and then can sort of move into more contact with other people. So there are this sort of thing gives you a lot of choices. They have a couple of things on these that are actually trademarked, but most of the things are pretty self-explanatory. And then pain or discomfort is another big thing that's a trigger for behaviors that are problematic for people. Often what they need then is, medical or nursing care, as is indicated here. But you notice that on this one, only one of the decisions off of the tree is providing medication to deal with discomfort. Most of it is, well, maybe you need to get them their hearing aid or their glasses because that's what they need because they're upset that they can't see well, or hear you, or other ways to respond to discomfort. Possibly they're too cold, they're too hot, and they're hungry. They need to go to the bathroom. These sorts of things. And when it's family members dealing with people, they know these things more intuitively. Not always, but usually. But in a care facility, it's really nice to have, here are the things I need to look for. And again, then it can get individualized over time for particular people, given the more common things that they need or the more common things they respond to. All right. And then I'm going to get a little bit into medication management. Basically, it's important to recognize the cause of symptoms in order to treat them. That may seem obvious, but sometimes we end up going down the rabbit hole of throwing medications at people because we've tried everything and, okay, we might as well try this one. Try really hard to avoid that. Really try to address a medication to an actual cause of what's going on. This really requires professional evaluation. A lot of times we'll have family members, definitely well-meaning, who say, I saw a commercial for X, for depression. Will you prescribe that medication for this person I care about who I see suffering? They're almost universally coming from a good place with that. The opposite is, this person, my family member is anxious, will you give them Xanax? Sometimes that's an attempt actually at drug seeking on the part of the family member. So that's another thing we watch out for. The med management requires pretty close collaboration between psychiatry and neurology, particularly if both of us are available in the same place. But the family and caregiver input is absolutely essential to establishing the diagnosis and getting the best treatment. So we really want to bring everybody in with this. Patient, family, caregiver is separate from family, and then both medical subspecialties if possible. So one of the ways that I think that social work can be really, really helpful, both to us as medical professionals and to patients and families, is to get an idea, to help communicate to the family and to the patient what information is really important for us to know. And it's not so much like we can't ask these questions. We can totally ask these questions. But if families are prepared to answer them, it makes everything go much more smoothly. And they have an idea of what we can and can't do. So it helps us do our job in less time, free up more time for other people in the visit to do their job, free up more time for physical therapy, occupational therapy, everybody else to come in and do their job and get people as much care and as the best care that we can possibly give them in the shortest amount of time, limiting their exposure to all of us, which is also honestly a blessing for most people. They get tired. These visits are really long sometimes. So we want to be as efficient as we can be to help them out. So one of the things, we want these basic questions answered. So, sort of who, what, where, when, not why, but how long. So what we want to know is, like, in terms of who, is a particular person more often or present or absent when a particular symptom is seen? Is there somebody who really helps the patient feel better? And examples of how this may play out is, for patient, the first guy, John, his agitation usually starts when his wife leaves for work. That's an important historical detail that we would want to know. Mary, on the other hand, her agitation doesn't really seem to depend on who else is present. Okay, and then in terms of what makes the symptom better or worse, what interventions have you already tried? What don't we want to go and repeat? What's helped with other family members? Because often, if there's particularly a medication intervention that's been useful for one person in a family, it's likely to be useful for another. And what else was happening when the symptoms started? So, John, he feels better when he can talk to somebody on the phone. He tends to feel worse when he feels really overwhelmed. Mary, on the other hand, giving her a snack usually calms her down. So, and then in terms of things related to where did the symptoms start? Where do they get worse? Where do they get better? John's agitation will calm if he can go outside. It will get worse if he goes to a crowded place. It also gets worse if he has a lot of things he feels like he needs to get done. Mary's symptoms are usually worse when she's away from her personal care home. So obviously John is less affected than Mary at this point, but we're dealing with sort of two different kinds of patients here. And then when did symptoms start? Is there a time of week, a time of day, a season, time of the year when symptoms are better or worse? For John, his first episode of agitation when was he wasn't able to reach his wife because she misplaced her cell phone. But he has started to worry for most of his life. He's been a worrier. Mary, on the other hand, her agitation started when she moved to the personal care home. She usually gets agitated about an hour before mealtimes. You can tell what's going on with Mary, right? Okay. How long do symptoms last? How long is it in between episodes? John's symptoms last until he can reach his wife, but they're most acute for about the first 30 minutes, and he tends to kind of calm himself down, even though he really wants to make sure that he can get his wife on the phone. Mary's symptoms last until she gets something to eat. So after a full evaluation, John's provider might say that we think this is really generalized anxiety disorder that he's probably had for most of his life, and that has basically gotten less easy for him to deal with on his own as his Huntington's has progressed, as he has a little bit less top-down control. And we're going to give him an SSRI, which is sort of the first treatment for generalized anxiety disorder. And then on the other hand, Mary's provider might think that, just offering her food more often would make things a whole lot better. Probably things got worse when she moved to the personal care home because she can't just go into the kitchen whenever she wants and get something to eat. And so, this is something that staff can do that will make everybody's life easier, and Mary will be much happier, and, everything will go okay. Oh, yeah. Much easier to do things before people get aggressive than after, the comment. And definitely because that gives the personal care home the investment in keeping the person rather the investment in getting them somewhere else. We always want to keep people in a situation that's pretty good and make it better rather than let it get to the point where things aren't so good and we need to get them to another situation, because it's so much, and you'll know this better than I do, so much harder to place somebody once something's gone wrong. Okay, so medication treatments for common problems. I think Dr. Valpy went over most of this, so I'm just going to kind of gloss over it. SSRIs, so things like fluoxetine, Prozac, sertraline, Zoloft for underlying anxiety or depression, either a typical or an atypical antipsychotic, for movement disorder plus impulsivity. Usually, people with HD respond better to the typical antipsychotics, but that is by no means a hard and fast rule. It happens that the typical more potent dopamine blockade works better for the movement disorder. So this is where you really want to be on board with the neurologist about treating the symptom, because often you can do dual duty with one medication where you can get movements and agitation, aggression, impulsivity, those sorts of things all in one pill, which is always good to limit the amount of medications we're giving somebody. A benzodiazepine, something like lorazepam, Ativan, diazepam, Valium, clonazepam, Klonopin, for acute anxiety. So we want to use this cautiously. As Dr. Valpy noted, these can be habit-forming. They can predispose to falls. The last thing somebody with Huntington's needs is another reason to be falling. For apathy, behavioral interventions are usually the most successful. We can give an SSRI to address any underlying depression. The SSRI doesn't help with the apathy, but if there is depression underlying it, it can help with that part of it. We can use Wellbutrin for depression and low energy. I would use that really cautiously, though. It can give some more energy. It can give a little bit of a kick, but because Huntington's tends to be a little hyperdopaminergic to start with, and bupropion works on the dopamine system, it's not first line. I wouldn't say I would never use it, but it's not something I'd use first. And then stimulants can be used also for apathy, but I find I have a whole lot better luck with them with my MS patients than with my Huntington's patients, because they can make the movement disorder a whole lot worse. And so, we're kind of stuck as far as apathy goes with Huntington's. Generally, or I shouldn't say generally, definitely behavioral interventions are the way to go. Okay, and so there are challenges in different care settings. when people are at home or living independently, it's really the ideal setting early to mid illness, but it really also depends on support from family and friends. I mean, the case that we talked about in our small group and then got brought to the larger group where, you've got a patient who's not got a lot of awareness about the symptoms that he's got and having a hard time getting services in the home for him. He doesn't have a lot of support, so it's really hard to keep him at home, and now wondering about whether he needs to be placed somewhere, even if he wouldn't necessarily need to be placed if he had a lot of support in the home. Keeping people at home requires a lot of education about family, about behavioral and other issues involved in Huntington's, and requires pretty intense family involvement, or also paid caregivers when Huntington's gets advanced. There's an increased risk of injury as the disease progresses, either because people are having a harder time moving if they have an akinetic version of the illness, or because of the chorea and loss of balance. And it can be difficult to institute some behavioral and other supportive interventions at home. Family needs really to be all on board. They need to be all in and not have, mom want to do one thing and dad want to do the other thing, and older sister thinks something else, and everybody's trying to implement their own thoughts about what's best for the person. That usually does not turn out well. So a lot of work can be done getting family all on the same page about what we're doing for people. In terms of long-term care setting, again, keeping everybody on the same team is one of the biggest issues in terms of taking care of people. You need to carefully communicate a behavioral plan to everybody who's going to be taking care of the patient. And it's really important along those lines to have one shift at a care facility sign out to the next about a whole host of different issues. This is going to be sort of more important. Different issues will be more important than others for individual patients. But things like, how well did the person sleep? Did they sleep on day shift? So we expect maybe they'll be up at night. How much did they eat? How much do they usually eat? Did they get any as needed medications? Were there any problem behaviors? Were there any interventions done over the period of the shift? Did anybody visit during the shift? How did that visit go? All those sorts of things should be pretty carefully signed out from one shift to the next, so that the people taking care of the person know what's going on and know, okay, well, they actually didn't eat dinner because mom was visiting and somehow that interrupted. So we need to make sure that they have access to food during the next shift. They usually take a nap, but they didn't today, so they may need to be prompted to go to bed earlier during this shift, that sort of thing. And then we always want to make use of caregiver strengths to the extent that we can. There may be one person on the caregiving team who's just really good at helping this particular person to bathe themselves. That's the person who should be doing that job then. I mean, it sounds obvious, but sometimes, we'll find out, oh, well, this person was assigned to that, even though this other person's actually really good at it. We want to do as much as we can to support the people to do the things that they do well and support them doing those things. And then we always sort of worry about staffing ratios in places. There's not a lot we can do about this except try to get people to a place where the staffing ratio is appropriate for them. But sometimes that's just out of our hands. So, other challenges of long-term care are things like regulatory limits. I'm not actually sure whether this is a Pennsylvania issue, but I think it's not. I think it's a Medicare issue where there has to be review of psychiatric medication use on a 30-day basis, or there's pressure to take people who are in long-term care facility off of psychiatric medications, particularly off of antipsychotics, and so these things need to be reviewed very frequently. It means you have to continue justifying the use of the medication that's appropriate for the patient, and that you need to do some good education to people who may be saying, but we're supposed to be getting people off of these medications. Okay, well, here's why we're using it. Here's the indication. Bringing people in so that we're all on the same page of why we're doing this when there are pressures from outside saying that these things maybe shouldn't be done. And there are actually good reasons for those regulations. They don't just necessarily apply to every case, and it requires basically collaborative care. and bringing people on board with what you want to do. Sometimes that's hard for me. I'm like, skip on the medication. And then the other thing is some places you can use as needed medications or PRNs for behavioral issues, and some places you can't do that. I've had to write orders for people in long-term care facilities that said, use this medication, except when they're not agitated, which is sometimes that'll fly and sometimes it won't. And it's really getting around the regulation for some places where you can't use a medication that's intended to be used only when they're agitated. Which what I'm trying to do is keep somebody in the place that's working for them, and every once in a while they get worked up and they need a little bit of whatever it is to help them calm down. And when staff is good and the agency is good, they'll work with us on how to accomplish the goals for the person without violating regulations. And sometimes you end up not being able to work with people to the same extent. And there are some people who I would rather have on less medication, who I have on a little bit more than I think is ideal because of the care setting where they are. And that's just one of the challenges that we need to deal with. And I think that's one of the places where advocacy can be as useful as one person prescribing medications. Okay, much more useful than one person prescribing medications. Yeah.
Can I just say one thing, and if somebody else can speak to this to better clarify? I know that some states have changed to specifically exclude HD from the requirement to titrate down. I thought maybe the federal regs had also. That being said, if a facility is not as familiar, if they don't have experience with HD, they'll still tell you they have to titrate down. So we usually have to tell them to go back and double check the specific HD regs. I still run into trouble with it, but I just wanted to comment on that. Also, then you have to work with them on how to properly document it so it's not a chemical restraint. But I do think that the regulatory rules with the titrating down with HD has gotten a little bit better than it. Anyone else speak to that? I just wanted to comment on that. But I think that's changed a little bit.
Yeah,
I still get pushback, but
most of the people that I actually have in long-term care facilities aren't HD patients. So most of our people that we see in clinic are not in long-term care facilities. So I can't actually comment on that. One thing I would like to comment on is actually just chemical restraint is a word that in practice, I mean, when we're speaking informally is one thing, but when speaking in the medical record, should not be used, which is not to be critical of you using it here, but to say that what we are doing when we're giving people medication to help them with agitation or aggression is to treat a symptom of their illness. And, yes. Yeah. Thank you for the clarification that the facilities are interpreting it as being chemical restraint when what we're doing is treating a symptom of illness, which we should be doing. We're trying to help people, not knock them down. Was there anybody else who wanted to comment on the regulatory?
Just saying, in the nursing home, the one thing that happens is that if you try it once and there's any negative outcome, then you can document never to do it again.
I usually just will document when I see the patient that it's not appropriate to do the titration, and it works okay. But yeah, certainly if you try it and it doesn't work, then that's good. Yeah. Okay. And so, good. And my computer says I'm just up on 60 minutes here. So the take-home points. Behavioral interventions are effective, can be used alone or with medication, and can be used in any care setting. Medications are sometimes necessary, need to be monitored closely for side effects, interactions, need to be reviewed regularly. And so, the regulations don't have it wrong in that we should be thinking carefully about the medications that we're giving people, and can be used differently, or may need to be used differently in care facilities due to regulations. Long-term care can be challenging, but it's also an opportunity to provide support for patients and families that can't be given any longer at home. Sometimes patients and families' relationships improve when somebody's in an appropriate facility getting the care that they need, and the family no longer has the caregiving burden. They can enjoy their time with the person that they care about without having to be providing care for that person on a 24-hour, 7-day-a-week basis. And that's, I think, what I've got for you. Thank you. Questions? Oh, I put you all to sleep.
I actually have a curveball a little bit.
Oh, yeah.
Because, one of the slides it talked about, the warning signs, like things to watch out for. And as you were talking about it, a case came to mind where there were no signs. So just really quickly, there's 3 siblings, one unaffected, 2 affected. The older of the affected siblings is really, really progressed. And the younger one, he looks great. He was recently diagnosed and, physically fit, just a really in a great place. Typically when we give a diagnosis, they just see the neurologist, the psychiatrist, and the genetic counselor, and then, that's it. He knew that this might be a possible diagnosis for him. He got his diagnosis. He said, you know what, we'll deal with it. And he was actually smiling. Now, we knew that he had a history of alcoholism, but that had kind of been, taken care of years before he was a patient in our clinic. Got his diagnosis, went home and said, I'm raring to go to fight this HD. A few weeks later, we get a call from the unaffected sibling, who is a police officer, saying that he had to go to the brother's house to remove his gun because he had, let this fester for a little while. He got some alcohol and then he threatened suicide. There were no warning signs going up to this point. Since then, he has spoken with our psychiatrist. He's never come in to follow up with any kind of outpatient intervention. Once the brother removed the firearm, got him some more help for the alcoholism. He reports back saying, I'm great. That was a one-time thing. So I wonder, what do you do when there are no warning signs?
Pray. That sounds flip, but in some relatively large number of cases of people who actually complete suicide, there aren't warning signs because they know that if they say something or let it show, people will stop them. Okay? In HD, where there's the added wrinkle of increased impulsivity, usually we see more in terms of warning signs because people aren't so good at keeping it under wraps. But it may be that somebody who actually does not feel most of the time that they have any desire to harm themselves, they may not feel depressed, will every once in a while have that impulsivity kind of kick in and do something, for lack of a better word, stupid. And be at serious risk of hurting themselves. I'm not going to be real helpful here. It's kind of part of the illness. We can do what we can do, and we can ask all the questions we know to ask. And we don't have it in our power to know for everyone, or intervene for everybody, I guess. The only thing I can do is validate and say we all do the best that we can, and we all do what we know we have evidence for being effective. And there's not much else we can do. We don't have a brain scan for suicidality. We don't have a blood test. We know that people who have HD are at increased risk, and so we watch them more carefully, which doesn't mean we get everybody.
I think that's the thing that most frightens me about this particular patient is that, after leaving the clinic, after getting the diagnosis, after speaking with the psychiatrist, everyone could check off that he is doing surprisingly well, with this diagnosis. And, what's interesting is that the other affected sibling had an appointment in the clinic last week, and he is the one who brought her in. So none of the other family members were present, just he and his sister. He himself has not had an appointment in the clinic, just because it's not time yet, for HD. But he brought his affected sister. And, while he was there, we thought we should check in with him just to see, what's going on. And the brother who he had called after he had gone on this binge, the one who's a police officer who went in and took the guns out of the house, from his report, we thought, okay, no more guns, he's fine. So he reported while he was there with his sister, he's like, oh, I'm great, I just got back from Texas. And all red flags, no disrespect to anyone who's from Texas, but the gun laws in Texas are a little bit less stringent. And we're like, so you just drove to Texas? And he's like, yeah, it was awesome. Didn't talk about what he did while he was there. But now everybody's like, what did he do when he was in Texas? Because he just presents as this really cognitively intact person, but, has these impulsivities that make us all,
anxious.
Well, no. So the genetics counselor, she did ask. But again, the appointment wasn't for him. Yes, we checked in with him, but he kept saying, this isn't about me, it's about my sister. This is her appointment, let's focus on her. He kept taking the attention off of him, going back to his sister. So, they did ask, but he didn't.
But he deflected.
He deflected, absolutely.
I think it's so hard because you don't know, and there's only so much you can do. We have a gentleman that I think he probably already at that point been in our clinic for 4 years and comes in as an excellent spouse, as a caregiver, every 3 months, clockwork to follow up with us, regardless if there's anything major going on. In almost 4 years, there were never any real he saw the psychiatrist every 3 months, but there were never any red flags until one day we get a call from the wife that she's on her way home from work because he called and he's sitting on their bed with the gun in his lap. And thankfully by the time she got home, he had put it away and had calmed down, and then we were able to have a good conversation about gun safety. But there were zero warning signs, and he was somebody that was well known to us. And the wife was always she's still very candid with us. So I think those are always the scary situations because you don't have the warning signs. One of the conversations we try to have about gun safety, and I don't know if you said this and I just missed it, was a lot of our patients that have guns are attached to their guns. they're not attached to their bullets or ammunition. So like,
fair, yeah, I left that part out.
So usually, like, the conversation that we try to have is, you can keep the gun that you keep, like, bedside that makes you feel better, can your spouse or can your family take the bullets away? And I find that most of the time that's an effective conversation, because it's just the idea of having the gun. Now I have another gentleman that has a collection of guns that won't even have a conversation about gun safety. He's really scary. He hasn't made any actual threat. He's never physically harmed somebody. Like, he hasn't met that threshold for us to be able to do anything about it.
And it's not that different in the general population. I mean, just to be clear, the HD, there's more impulsivity and leading to possibly more action. I mean, and higher rates of attempted and completed suicide. But a lot of these lack of warning signs, a lot of the things that I'm hearing are common in the general population as well, just more common in HD.
Well, we know some risk factors, sudden unplanned placement. So we do try to have conversations very early on of what is going to be your plan if something should happen to your caregiver. Your caregiver could have a sudden health crisis. Your caregiver may need a break. Because we did lose somebody where that discussion didn't happen. The wife went into the hospital with cardiac arrest, and he did complete a suicide. And then we also know driving is a risk factor, and people are very cautious about even bringing up the discussion of driving. They talk about having an independent driving assessment, but also we can try to talk about alternative transportation modes.
I think that's true most places in the country with the driving, and we do a lot of referral to an occupational therapist to do a driving assessment so that people can see where their deficits are, and even still, they still want to drive.